Hey Pete, I've tried everything in this place for my severe hay fever. Could you prescribe me something?
Thank you, Leah, for that question. So before we prescribe anything for hay fever, we first need to ask ourselves, is this definitely hay fever? There's loads of ways the nasal lining can become irritated, and the person's symptoms could be the result of a whole host of causes, like the dust from building work, chemicals, pollution, ACE inhibitors, vaping, cocaine. The list is really long and difficult to remember, but thankfully, NICE summarise it excellently in their CKS guide here. If we're happy that they have allergic rhinitis, stay in this document and revisit the lifestyle advice here. This has some brilliant recommendations, and these can often be game changers that are regularly overlooked. With these two important things covered, we can finally start looking at some treatments. So at this stage, we definitely would expect this person to be using a steroid nasal spray. And thanks to the previous video, they know how to use it. But remember, not all steroid sprays are equal. Some have much higher potencies or longer durations of action, and this can be used to our advantage. My first line recommendations are usually beclomethasone or mometasone, but then the second option I would tend to turn to in these circumstances is one called Avamis, or fluticasone furoate. This is a much higher potency version of fluticasone that has a long duration of action, and this is usually my first option for people who are struggling. If your patient has asthma, check if they're on Montelukast. If not, the mast cell stabilising effects of this drug provide great benefits for both hay fever and asthma. Remember, start with a trial of 8 weeks and always counsel patients on the risk of psychiatric effects highlighted in the recent MHRA alert. Another option in some guidance is adding an intranasal antihistamine. We don't see these treatments that often, but their evidence base is actually quite good. They're a bit more expensive than oral antihistamines, and if we give them as a separate spray, they can be a bit of a faff for patients alongside their steroid spray. There are combination preparations available, but the most readily available option, called Dimista, uses fluticasone propionate, which is a bit shorter acting than Avamis, so it has to be used twice a day instead. One final option involves using certain antihistamines at doses higher than their licensed dose. You may have seen other clinicians at your practice doing this, but before we talk about it, remember this is an off-label recommendation. There's lots of additional responsibility you take on as a prescriber with an off-label recommendation, so it's really important that you're fully aware of the guidance before you consider this for your patients. I can't emphasize enough that patients should never exceed the recommended dose of a treatment unless specifically instructed to do so by a prescriber. With all this in mind, there's evidence that the second generation, or non-drowsy antihistamines like cetirizine, loratadine, and fexofenadine, can be helpful for managing urticaria at up to 4 times the licensed dose. This started to become a widespread practice, and as experts started to see the effectiveness for this condition, they started to wonder if it could help other conditions like rhinitis. Whilst the evidence base for this isn't as strong as for urticaria, there could be a role for using these doses in managing particularly resistant cases of rhinitis. If you are ever considering this for your patients, there's a few key points to remember. These are non-drowsy antihistamines, but at these doses they'll almost definitely cause drowsiness. So counsel patients on this and the potential impact on driving or using tools or machinery. This is also strictly only for cetirizine, loratadine, or fexofenadine. You should never exceed the licensed dose for older antihistamines like Piriton, as this can be very dangerous. Remember as well, the evidence base for this is not as strong for rhinitis as for urticaria. So if you're prescribing this for a patient, I would recommend beginning with a cautious increase from once a day to twice a day first. There are other treatments out there. A lot of these are specialist only, like immunotherapy, but I've had several patients ask me recently for intramuscular steroid injections. Technically, these could be given in general practice, but I never use these for allergies. The evidence base for them is quite inconclusive, and there may be a role somewhere for them in particularly resistant cases, but I feel this decision should be made by an ENT or immunology specialist, so I would refer to them for advice. So there you have it. You now have lots of routes to help your patients with their resistant hay fever. See you next time.